for the next 15 minutes, I'll be talking on energy sources that we commonly use in our laparoscopy OT setup. First of all, I'd like to say that any laparoscopic surgery or any surgery is like a journey. You have to reach your destination. You have to start from somewhere and you have to reach your destination. For that only, for any journey, like we choose our vehicle accordingly. If you have to go nearby market, you can go by cycle. But you have to go to the other city, you can avail car or train or plane. So you have to choose your vehicle wisely. Likewise, in operation theatre, for any basic or advanced laparoscopic surgery, you have to choose your energy devices wisely. So I'll explain how. So we have to start from the beginning for the history of invention of energy sources. It was way back in 1877 when Dr. Philippe Bozzini started the concept of electrocauterization, and but it was no later than 1928 when Dr. Harvey Cushing is the gentleman Harvey Cushing here, and he collaborated with a great physicist that William Bovee, and they discovered the electrosurgical equipment. This is the electrosurgical equipment that was invented way back in 1928, and there they started the different concepts of dissection and coagulation. And in 1933, Dr. Farr was first, who is a general surgeon, who did laparoscopic adhesivolysis in 1933. But later on, newer energy devices came up. But you have to understand what are the temperature effects on the different types of tissue. The most important thing is when I do coagulate our tissues, usually the temperature is around 60 degrees centigrade. But if you increase the temperature, and there is carbonization starts at 80 degrees centigrade, and 100 degrees centigrade complete cellular destruction, and destruction by vaporization. Actually, the water content inside the cell is vaporized and the cell burst actually. And 125 degrees centigrade is actually complete eschar formation. So we have to use our temperature setup in our monopolar diathermy wisely so that we can put the desired effects on the tissues that we are going to coagulate or cut. So what are the different energy types that are available in the operation theatres? So most commonly the electrical energy, where we use electrons to generate from the electrosurgical generator, and it will travel through the patient's body and go back to the generator only in monopolar diathermy. And there are bipolar diathermies, and there are newer bipolar devices or newer vessel sealing devices like Ligasure, plasma trisector, NSEAL. Then there is radio frequency ablation. These are all electrical energy were used. Then there comes the mechanical energy. Mechanical energy, what is that? That harmonic scalpel, where we use ultrasonic energy, where in electrical energy, the electrical energy is converted into heat energy. But in mechanical energy, the sound energy is converted into heat energy to produce the desired effect. And then there is light energy like photons, where we can use laser in different surgical procedures. So we'll start from the monopolar devices. I think most of you know the actual concept of monopolar energy, where this is the electrosurgical generator. Once you press the pedal in your feet or in your hand, there is handpiece. If you press the pedal, then the electrons are coming through the electrical surgery. This is the active electrode, and then through your handpiece, through the tip of your handpiece, it will be the electrical energy will be delivered into the patient's body, and it will be converted into heat energy, and they will produce the desired effect. And the electrons will travel through the patient's body, through the path of least resistance, and this is the return electrode pad that we usually put on the thigh of the patient, and through that return electrode pad, the current energy will dissipate and go back to the return electrode, and this will complete the circuit. This is the concept of monopolar energy. Then what are the different things that we need to understand about the monopolar energy? You have to understand what are the amount of current density you want to deliver. Suppose you want to dissect in laparoscopic cholecystectomy, you want to dissect the tease of the peritoneum, or you want to dissect the callot strangle. Some of us use hook for the callot strangle dissection, some of us use Maryland forceps. The tip of the instrument depends on what amount of current density to be delivered. If the tip is big, then the current density will be less. If the tip is small enough or fine enough, that current density will be more. So depending upon the tissue you are going to dissect, you have to choose your instrument through which you want to transmit your electrical energy to produce the desired effect. And then again there is some confusion whether to use cutting mode or coagulation mode, but most of the cases, most of the laparoscopic cases, we use coagulation mode in laparoscopic surgery. But you have to understand why we are using coagulation forces and why not cutting. So cutting, here you can see the waves are continuous waves, and that means the frequency is more but the voltage is less. So in small amount of time a lot of energy is delivered and heat production is more. So in suppose you put a cutting pedal for 10-15 seconds, it will produce so much of energy in the tissue that it will cut without cauterizing, and it will cut the tissue, but there will be bleeding because the vessels are not cauterized properly. It will cut. But in case of coagulation, where frequency is less, you can see in the same duration of time only 3 impulses there. So voltage is more but the frequency is less. So in that way, that amount of energy is produced should be ideal, so that you can coagulate the tissue, that you can reach up to the 45 degrees centigrade. But if you use the cut mode, in the same duration you can reach up to 100 degrees centigrade. So that is the thing you have to understand. Again, there are various blend modes where you can use cutting and coagulation. Coagulation, there are 2-3 types of blending modes. Then cutting, there are blend 1, blend 2, blend 3, where you can monitor or you can adjust your amount of energy to be delivered and the mode of energy to be delivered. But the most important thing you need to understand, what are the electrosurgical injuries can happen if you don't understand the mechanism of this monopolar energy devices. Number one is direct coupling or insulation. Most of the reason it is insulation failure. Then the conductive coupling and the capacitive coupling. I will explain how. Whenever this is suppose this is your right hand instrument. This is your right hand instrument. This is the port, and this is outside. This part is remaining outside of the patient's body. Then this is the port. This is going through the abdominal wall. So this can be divided into 4, the whole thing can be divided into 4 zones. The zone 1, which is visible in the monitor, the tip of the instrument and a part of the proximal part of the insulated instrument. Then this is the zone 2, this zone 2 is the blind end. And zone 2 is not visible in the monitor usually. Okay, if you are going close to the subject, you are going to dissect, then zone 2 is ideally actually not visible. Zone 3 is through the abdominal wall, and zone 4 is outside the body. So what happens is zone 1 injury is actually the pilot error. Pilot error means if you are not comfortable enough in using the cautery, you can inadvertently injure the unwanted tissue. Like if you are trying to lift up the gallbladder from the liver bed. So if you are not comfortable enough, because you are looking at monitor, your hand is regulating the instrument, and you are trying to put the pedal through here. So 3 part of the body doing 3 different things. They have to be in a sync. If you are not in a sync, if you are pressing the pedal while not looking into the monitor, you may injure the duodenum. Suddenly the current may activate and injure the duodenum or the stomach. And these are very high electrical sources. In a small amount of touch of electrical energy can later it can develop maybe duodenal injury in post-operative period. It may do duodenal injury. The duodenal perforation can lead to duodenal perforation. Then it can lead to, if you are touching the bile duct, later it can develop bile leak or biliary stricture can develop. So you have to be very cautious. You have to be trained enough. You have to train yourself enough and be comfortable what you are using. So as Anmol said, that ergonomics is very important. So while using this instrument, using these energy devices, you have to be very cautious about it. Then what is zone 2? Zone 2, there are 2 different mechanisms of zone 2 injury. Zone 2 injury means the sheath, that is the insulation sheath that is covering your instrument, should be intact. There should be no breach in the insulation. So you have to regularly monitor your instrument while washing the instrument, whether you are washing or your scrub nurse is washing the instruments after the procedure. You have to use at least one magnifying glass and check whether there is any breach in the insulation. Because continuously you are not taking care of instrument, there some kind of over the time there should be some kind of injury, and there is everything has a lifetime. So some point of time there will be one breach, and that may cost you more, because when you are with the tip of the instrument, you are trying to coagulate something, If there is breach in the insulation, the energy can directly jump from that instrument and into the nearby bowel, and it can cause severe bowel injury and a post-operative complication. So no patient can expect that while doing laparoscopic cholecystectomy developed a fecal fistula or peritonitis. So that should be taken care of. So insulation, take care of your instruments properly, do regularly check, ask your scrub nurse, or you yourself do regular check on your insulation part, each and every instrument. Then there is another mechanism of zone 2 injury. There is direct coupling. What is direct coupling? Direct coupling is when there are angle is less, that manipulation angle or whatever angle this Dr. Anmol said, when there is too crowding of instrument inside the abdomen, then from one instrument, the energy can, that electrical energy can jump into the other instrument through the laparoscope, which is a metallic instrument, and this is not insulated. Laparoscope is not insulated, and it can injure the abdominal wall or intra-abdominal viscera. So while applying energy with one instrument, you should take care that other instrument should be little away from that energy device that you are going to use, mainly that monopolar cautery or something. So this is again conductive coupling. This is known as, whatever I told, it is known as the chopstick phenomenon. So unintentional contact of active blade on some other metal instruments. This should be avoided. Then there is capacitive coupling. What is capacitive coupling? Capacitive coupling is rare nowadays. Initially in the maybe 20-30 years back, when used to use, if after putting the port, if you one surgeon find it is loose, the port is loose, port is getting inside the abdomen or port is coming out, then we used to use like one plastic cannula, through which we putting the plastic cannula, and then we put the total instrument inside the abdomen. We don't use this plastic cannula nowadays, but it can cause zone 3 injury. How? Because here we are using the metallic cannula, that is a port. Here the energy is traversed, and through the metallic cannula it dissipates through the abdomen and then go back to the return electrode, and then go back to the electrosurgical generator. But here, if you are using metallic cannula, the energy that is going through the metallic instrument, it cannot dissipate through the, because this is a plastic protector is there, so it cannot dissipate through the intra-abdominal, abdominal wall. In that case, the energy is stored in that metallic port, actually that port, and sometimes after a certain period of time, when there is huge amount of collection of electrons in that port side, which is not dispersed through the abdominal wall, it traverses directly, it can jump onto the bowel, nearby bowel, and cause bowel injury. So these are all, you also get this MCQs in your competitive exam. So you have to be very clear about what is capacitive coupling, conductive coupling, direct coupling. So this is another method of doing capacitive coupling is now less, because we are not using any plastic cannula nowadays. Most of this we try to avoid this. So whenever after in any part of the process, suppose after dividing the cystic artery, you see there is, the clip is not properly applied, and they started, even after application of clip, there is some bleeding. So you thought, okay, I have energy devices, I will touch that cystic artery, the remaining cystic artery, and it will coagulate. But don't do that, because whenever you apply energy to any metallic nearby any metallic clips or metallic, it will transmit the energy. It will produce great amount of heat, and it will ultimately traverse, the energy will ultimately traverse through that metallic clip or whatever staple is there. Then it will traverse through the nearby structures, and it can cause bile duct injury or hepatic artery injury. It can cause. So better, if there is some bleeding, the most important thing is put one gauge piece, put it over there, wait for some time, the bleeding will stop. Even after that, if it is not stopping, then you can use suture if you are good in suturing, or if you can call for help, who is competent in doing all this procedure. You can wait, you can put a gauge, ask the anesthetic to come, decrease the blood pressure, control the blood pressure, inform them there is some kind of bleeding, I need time to control it. And it will ultimately, most of the bleedings, small arterial bleedings will stop with compression, adequate compression. 5 minutes, 10 minutes you can use. But don't use any energy upfront. Similarly, this is a case of sleeve gastrectomy. Even after sleeve gastrectomy, there can be staple line bleed, or any after staple application, there can be staple line bleed. So you don't apply any energy inadvertently. Better to clip it from the bleeding point or put some stitch. There are lots of advances in electrosurgical area. There is tissue response generator, there are split return electrode, active electrode monitoring, voice command system. All these are to avoid these electrosurgical injuries, to make it more safe. So these are the things you need to know before starting your laparoscopic practicing career. The return electrode monitoring is when we use a split return electrode where there is two wear actually, and there is sometimes during using this monopolar cautery, this return electrode pad may come off. If it come off from the body of the patient, the electrosurgical generator will automatically stop. Even if you press, the electron will not come. So there is an interrogation circuit which controls the delivering of electron from the active electrode. If the return electrode pad is dislocated or partially come off from the body, then the interrogation circuit will inform the electrosurgical generator and it will stop delivering active electrode. It will automatically stop. Then there will be some alarm, there will be color change in the electrosurgical generator, you will get to know. So these are the newer things developed. Then there is another monopolar in a diathermy device. There is argon plasma coagulation, where in between the electrode and the body there is argon plasma source, where the electrosurgical it will deliver the electrons in a spray mode, like there is some bleeding from the liver surface, then you can use it like a spray method, like coloring spray method. You can coagulate the surface coagulation. Mostly argon plasma coagulation is for surface coagulation. Not much into till now, not much into use into laparoscopic surgery, but slowly it will also come up while doing a liver resection and all this by laparoscopy. Then bipolar diathermy. Bipolar diathermy, see, from the image only you can understand this is a closed circuit. So the both active and return electrode in your handpiece. So this is much safer. The patient is not part of the circuit. So it is more safe, but whether it can dissect tissue, whether it can cut tissue, no. So bipolar can coagulate tissue, but it is difficult to cut or dissect the tissue with bipolar forceps. For that only later newer bipolar devices came. The first of all, this Ligasure vessel seal system. What is this? It is a bipolar only. Bipolar low voltage, it will deliver low voltage high current, and it will produce both mechanical and thermal effect. And the collagen elastic welding mechanism is there to coagulate the tissue. It's a very handy tissue. It can dissect, you can coagulate, you can divide, and you can do advanced laparoscopic surgery. It can seal up to 7 millimeter vessel. Then there is another newer bipolar device, the gyrus plasma session. It is not much into use nowadays, but it is when it was invented, so many laparoscopic surgeons used it. It uses the vapor pulse coagulation to coagulate the tissue. Then there is NSEAL. You can see this probe, the tip of is having smart electrode technology. So the mechanism is thermofusion and dissection. This is again bipolar energy devices with smart nanotechnology is there. It will anticipate the tissue depth, and it will coagulate with thermofusion and dissection. You can dissect, coagulate, cut, you can do everything. So these are newer bipolar devices. But key points for practice is always use low voltage form in laparoscopy. Don't use high voltage. 30, 35, 40 is good enough for most of the procedure. Lowest power setting is possible. Short burst of current. Don't press the diathermy pad for long. Diathermy paddle for long. Just short burst of current you should be giving. And bipolar, if you have, it is better. Wherever it is required, if there is some coagulation, you need to do vessel coagulation, use bipolar current. Avoid what should be avoided? Activating in open circuit. If your laparoscopic instrument, suppose hook is not in use and you are pressing the pedal, it can injure the outside of the body of the patient. Temperature, the energy can go through the drape, and there can be skin burns. So that should be avoided. It should not be activated near any metal object. I have described. Using instrument with insulation failure, that also I have described, and hybrid trocar system, that is the plastic trocar cannula. Then there is mechanical energy sources. The most important thing is harmonic. Harmonic is very handy. It uses ultrasonic energy, and this is the active blade. This is the active blade, and this is the gripping blade. This is the whitish. This is for using for gripping the tissue, and this vibrates at 55,000 per second. And it causes so much of vibration, and causes that sound energy into heat energy, and it can be used as dissector, it can coagulate, it can cut, and it produces up to 80 to 100 degree temperature and minimal lateral spread, 1 to 2 millimeter spread only. So this again, but if you have harmonic also, but again after application of the harmonic, you should take care of that. After using, you should not touch the bowel, because that active electrode is very hot while you are in use. So you should be very cautious while using it, because after producing the desired effect, you should not touch anywhere else with that probe. Then there are different kinds of blade configuration, power level up to 1 to 5, traction, tension, both can be used, and residual heat that I have already told. Then, so what to do, bipolar or harmonic? Hemostasis, bipolar causes more hemostasis, harmonic causes more dissection. And so the Olympus and inverted thunder bit, where you can, there is combined in ultrasonic and bipolar energy devices you can use. So this is the latest, and this is the best energy devices available in the market, obviously a bit costly, but if you have it, you can do any advanced laparoscopic surgery if you are competent enough. Then laser is not much into laparoscopic surgery as of now, but it will again come in the future. So energy devices for much, which is best? Ligasure, Ensil, Harmonic, but which is best? I think you have to decide which is best, but which you can easily handle, which is reliable. After using it, you find it efficient and it is cost effective. And the ideal energy source should have maximum basal bus pressure, at least 3 times of the systolic blood pressure. Okay, then least thermal spread, least amount of smoke production, and fastest sealing time. So if you have a monopolar devices in your OT setup, you should have one bipolar devices in your OT setup. And if you want to do advanced laparoscopic surgery like that, so I would recommend you buy, if you want to buy anything, buy any one of these 3. Either Ligasure, either Harmonic, Ace, or Thunderbit. And finally, to conclude, that with great powers come great responsibility. So Peter Parker said. So these are the great powers that we have nowadays, but these you need to train yourself properly to use it for the patient's good. Thank you so much.